Welcome to Oncology for the Inquisitive Mind and the first in our mini-series of ASCO 2023. As we mentioned in our ASCO appetizer, Josh and I will be going step by step, tumour stream by tumour stream, and summarising some of the major updates and new research being presented in Chicago. Unfortunately, we're not presenting from Chicago, but we will nevertheless attempt to bring the spirit of ASCO across in audio form. I am joined as ever by Josh Hurwitz, Honorary American. How are you doing?
I'm doing very well. Yes, there are a lot of Josh Hurwitzes in America, and I assure you I'm none of them.
And his wife went to Columbia University, so she's American in all but passport.
An alumni.
And yes, exactly. So our first episode today is focusing on some of the updates from the upper GI space. So we have identified 4 studies that we wish to go through with you, 3, incredibly, in the pancreatic and biliary space, but we'll get to those in a minute. Josh, to start with, why don't you take us away with toripalimab study in the gastric and GOJ space?
I will. The first thing to learn is how to pronounce toripalimab, but here we go.
I find that's the case with a lot of the medications, particularly the immunotherapies being presented at ASCO.
Really is.
Have to really sound it out.
We do. So this is a study looking at toripalimab plus SOX, which is S1 and oxaliplatin, or Zelox, which is capecitabine and oxaliplatin, versus SOX or Zelox alone, which is the capecitabine and oxali for locally advanced gastric or gastroesophageal cancer. So what is the elevator pitch? Why do we care? The reason is immunotherapy has struggled to gain a foothold in early gastric and GOJ setting. It's sweeping many cancers like a Taylor Swift concert. Everyone's getting immunotherapy. And the question is, it may improve recurrence-free survival in patients with resected disease. The standard of care therapy at present is FLOT, and we've spoken about it in one of our previous episodes, so check that out. So this is a phase 2 study comparing S1 and oxaliplatin, or Zelox, plus or minus toripalimab. They were given 3 weekly cycles, 3 weekly pre-op, so every 3 weeks, followed by 5 cycles post-op, and toripalimab continued for 6 months. There was no placebo control. There are 108 patients in this study, and the eligibility criteria is, large gastric and GOJ tumors, so T3, T4, node positive, and a good performance status. They were stratified according to location and also the different intestinal differentiation classifications from Lauren, which is diffuse or intestinal or mixed.
And we might include a summary of Lauren's classification in the episode description.
For your pleasure.
And edification, yes.
Primary endpoints: pathological complete response or near pathological complete response, and secondary endpoint was a whole host of things. The things we care about: toxicity, overall survival, R0 resection, where you get all the cancer and there's nothing left, and a couple of other sprinklings, the recurrence-free survival as one. Baseline characteristics: most were under the age of 65, ECOG was 0, majority gastric and intestinal, and stage mostly T4, so quite large with lymph node involvement, and 61% had SOX. With the results, tumor regression grading, which looks at how much has the cancer died when you're giving neoadjuvant treatment, so 22% had TRG of 0, which is essentially a complete pathological response, versus 7% and statistically significant. Combined 0 to 1 was 44 versus 20%, and 93 to 94% had an R0 resection rate, which is pretty phenomenal. There were similar rates of surgical complications and similar rates of toxicities, so 96 versus 93% for adverse events of any grade and 35 versus 30% for adverse events of grade 3 to grade 4. Immune-related of any grade was about 13%, and grade 3 to 4 was about 2%, which is in keeping with most other PD-L1 inhibitors. And I don't think I mentioned, but toripalimab is a PD-1 inhibitor.
Probably should have included that at the start, but we'll retroactively apply that.
That's it. So what the important things to talk about here is you definitely saw a TRG 0 that was superior to that of standard of care chemotherapy, at least almost triple right? And if you combine it with TRG1, which is most cancer dying, it was, double there again. And if you add the two, that's 44% at least. So this is really a good outcome. So what we see as a conclusion, increased pathological response. Compare and contrast to prior studies, which is the Attraction 5 study, which was nivolumab, another PD-1 inhibitor. It did not demonstrate statistically significant benefit in recurrence-free survival, though the endpoints were different. So it wasn't a positive trial. Also, it did another limitation of this study is it didn't actually use the standard of care that we use, which is the FLOT regimen. So unsure, would it actually be better if you gave the standard of care? Would it actually be slightly worse because the standard of care would be more efficacious? It's a bit hard to say.
And Josh, just for our listeners who may not be aware, what is the difference between, we'll call it FOLFOX or CAPOX because in Australia we don't have access to S1, but what is the difference between FLOT and FOLFOX?
So the difference between is that docetaxel is in FLOT. So it's fluorouracil, oxaliplatin, and docetaxel. First of all, FOX is fluorouracil, oxaliplatin, leucovorin as sort of the combination therapy. Docetaxel you see a lot in the breast cancer space, so I use a lot of this. And
you also do see it in later lines in treatment of gastric cancer. So we know that taxanes have an effect in the upper GI space. So you don't know how much additional benefit the docetaxel is giving. It's probably not huge, but again, we don't know that.
We don't. So there are limitations to this study, but it is a curious question that they've asked, and it's an exciting question that they've asked. And I look forward to seeing larger trials looking to see if this actually improves outcome. The rationale, as a summary, is that gastric and gastroesophageal cancers are pretty difficult to treat, both from a morbidity from surgery, morbidity from chemotherapy. I've had patients who've had neoadjuvant FLOT and they just never end up on any adjuvant therapy because post-gastrectomy, they just really struggle. But Michael, I could talk about quality of life stuff till the cows come home. Why don't we talk about Napoli 3?
Absolutely. Napoli 3 is one of the, or Napoli 3 as Josh calls it, is one of the several pancreatic and biliary cancer trials that we have highlighted for this episode. The elevator pitch for this one, I think we're just going to call it that now, is that obviously pancreatic cancer is notoriously treatment resistant. There have been so many negative studies of novel agents in pancreatic cancer that has become a bit of a cliche. One limitation of many previous studies is that new agents have been compared to the historical standard of care, which is gemcitabine, or in some cases, capecitabine and gemcitabine. There have been very few, if any, to my knowledge, head-to-head trials comparing to the current standards of care, which is gemcitabine plus nab-paclitaxel or FOLFIRINOX. That is where Napoli 3 really sort of makes its money, I guess, because it is comparing. This is actually comparing NALIRIFOX, which is nanoliposomal irinotecan,
A
with
mouthful.
it is a mouthful. That's why we just call it NALIRIFOX versus nab-paclitaxel and gemcitabine. So it is effectively FOLFIRINOX with a slightly more advanced formulation of the irinotecan. Napoli 3, I think we might have mentioned it in a previous episode because it has been determined to be a positive study with a benefit of NALIRIFOX over gemcitabine and nab-paclitaxel. However, this is an update of the 12 and 18-month survival data. The primary endpoint for Napoli 3 was overall survival, and the secondary endpoints were progression-free survival, overall response rate, quality of life, and biomarker assessments. The latter two are still undergoing analysis and so weren't presented at ASCO. So the median overall survival for NALIRIFOX was 11 months versus gemcitabine nab-paclitaxel at 9.2 months with a hazard ratio of 0.83. The 12-month survival was 45.6 versus 39.5%, and the 18-month survival was 26.2 versus 19.3 months. So modest but significant increases in outcomes for what is a very difficult to treat disease. The benefit, if we look at the forest plots, was most seen in patients with higher volume disease, defined as patients with 3 or more metastatic deposits, patients with a good ECOG status, and interestingly, older patients, the subgroup of patients that was greater than 65. In terms of progression-free survival, again, small but significant benefit, 7.4 versus 5.6 months, with a 12-month PFS of 27.4 versus 13.9%, and an 18-month PFS of 11 versus 3.6%. Josh, I don't know about you, but I can count on probably one finger the number of patients on current standard of care treatment with pancreatic cancer that have lasted 12 months, much less 18.
Yeah, you're pushing the limits of the efficacy of this treatment. I would generally be looking for second line options or trials relatively early on because it's just difficult to control.
It really is. And so you really have to start scraping the bottom of the barrel fairly quickly, which is one of the main challenges with pancreatic cancer. There were higher rates of partial response radiologically in the NALIRIFOX group, higher rates of disease control, and a higher duration of response. In terms of toxicity, we've sort of been through this, but there were higher rates of non-hematological toxicity, so diarrhea, nausea, vomiting. However, there were interestingly lower rates of hematological toxicity in the NALIRIFOX group. So your day-to-day toxicity for the patient is probably higher, and we might see this borne out in the quality of life data that will presumably be presented at some point. However, the stuff that is more likely to cause treatment delays or dose reductions in terms of hematological toxicity appears to be less. So, in conclusion, the authors put forward the data that shows that NALIRIFOX demonstrates a continuing benefit over gemcitabine and nab-paclitaxel with expected toxicity. Now, the discussion around this was really interesting, and it's sort of a discussion that I think we had in the previous. I think it was our GI conference update from earlier in the year, Josh. But Napoli, one of the major things that we wanted to see was actually a comparison of NALIRIFOX to FOLFIRINOX to really get a sense of the benefit of this new formulation of irinotecan, which I'm not going to say again because I'll stumble over it. The Naliri is much more expensive. Irinotecan is fairly dirt cheap as far as chemotherapies go. So you'd want to see a significant benefit. And in the discussion panel, they actually brought up a cross-trial comparison, which, we shouldn't do, comparing NALIRIFOX to FOLFIRINOX from the Prestige Accord trial from a few years back. And the numbers are very, very similar. The median overall survival is virtually identical, as is the overall survival rate at 12 months. 18 months, NALIRIFOX starts to pull ahead slightly. PFS is slightly better, the response rate is slightly better. FOLFIRINOX has higher rates of neutropenia and lower rates of non-hematological toxicity. So the difference between FOLFIRINOX and NALIRIFOX is unknown. And what the panel discussion took away from it is that FOLFIRINOX, independent of where NALIRIFOX ends up slotting in, should really be considered a first-line standard of care, given that it is now in two separate studies have demonstrated very similar results in terms of outcomes, and they're both superior to gemabraxane, but this is the head-to-head comparison that we might have been searching for.
It is a head-to-head comparison, but it's a dirty head-to-head
Yes,
comparison.
exactly. Yeah. It's not exactly one-to-one.
Michael, you did mention some vital points that I might harp on a little bit more.
I know you love to harp, Josh.
The first thing, the toxicity profile. If these patients can tolerate NALIRIFOX more than FOLFIRINOX, theoretically, then it would be a great option. The cost, liposomal irinotecan is prohibitively expensive versus classical irinotecan. I think they were saying in the presentation it was like $38 USD versus $5,500 per cycle, and the benefit and risk and financial toxicity, especially to those in the States, could be huge. And I don't think Australia would probably approve it based on this data.
No, I don't think so.
And while it's better than gemabraxane, we already knew it's better than gemabraxane. This isn't a game. We already knew that. So I think it's
But I
just
guess we haven't had the comparison because we've been sort of reduced to doing cross-trial comparisons because neither the FOLFIRINOX study nor the gemabraxane study directly compared it to each other. They compared it to single-agent gemcitabine from memory.
Yeah,
Whereas this
that's true.
is, as you say, something of a dirty head-to-head, but it is a head-to-head that shows a triplet chemo is better
Superior.
to the gemabraxane. The flip side, though, is that gemabraxane, at least in my experience, is usually fairly well tolerated. I think there's still a little bit of hesitancy to give FOLFIRINOX up front. And we've mentioned this before, but in Australia, you can only get gemabraxane in the first line. So maybe there are some places where you give gemabraxane so you can use it under the PBS and then give FOLFOX or FOLFIRINOX as second line. But there are a lot of patients who wouldn't tolerate FOLFIRINOX, which you alluded to before.
That's true. So lots of considerations in this field.
Absolutely. From the metastatic pancreatic setting to the early setting, Josh, do you want to talk about NORPACT-1, which we mentioned in our appetizers episode, but didn't quite stick the landing? Spoiler alert.
Yeah, I know. It just didn't stick the landing, but it's still an elevator pitch. It's still a good question to ask. What is NORPACT, or what is it asking? In the early stages, recurrence rate for resected pancreatic cancer remain prohibitively high despite our chemo, despite our surgery. Patients with early pancreatic cancer are frequently deemed borderline resectable at the multidisciplinary team meetings, and thus neoadjuvant FOLFIRINOX has a benefit of potentially converting unresectable patients to resectable. There hasn't been any data in patients who are deemed resectable up front. So if you give neoadjuvant and resectable up front, do we have trials to support that methodology? This trial, NORPACT, looked at short course neoadjuvant FOLFIRINOX in pancreatic cancer deemed resectable up front. So key eligibility criteria: radiographically resectable head of pancreas cancer, no arterial involvement, less than 180 degrees interface with portal superior mesenteric vein, and no metastases. Those 3 points that I just mentioned, the artery, the veins, and the mets, are really what makes something borderline or unresectable. They've got to be over 18, a good performance status. So trial design, biopsy proven, you're given 4 cycles of FOLFIRINOX, then you have surgery, then you have adjuvant FOLFIRINOX 8 cycles, with the subsequent control arm being surgery, followed by 12 cycles of FOLFIRINOX, with the primary endpoint being overall survival. 140 patients in this cohort. 83% started neoadjuvant therapy and 17% failed EUS or FNA, which is understandable. It's a difficult biopsy. A lot of the time, you'll have a CA19.9 of 25,000 and you just can't get a biopsy. So people treat presumptively.
And you have sort of vascular anatomical considerations. These cancers are frequently in very inconsiderate spots.
That's it. And so 82 versus 89% made it to surgery. Well, surgery up front, you're thinking if they don't make it to surgery up front, they've obstructed, they potentially died, there's some complication. So 18% versus 11% developed metastases or suffered toxicity to death. So 18% is kind of favoring that neoadjuvant arm, and 66 versus 75 started adjuvant chemotherapy. So what we saw, higher rates of toxicity in the neoadjuvant chemo group and inferior survival in the intention to treat as per protocol, with a hazard ratio of 1.52. So p-value of 0.096, which means I got the dud of the trial. No, but it's a really important question. So it's not a dud of a trial. It's actually really important. So we saw higher rates of toxicities, inferior survival, intention to treat. Proportion alive at 18 months was 60 versus 73%. While that wasn't a statistically significant number, numerically it's significant. There were higher R0 resection rates in the intention to treat population, but it was not statistically significant. And in the per protocol population, R0 resection was seen in 59% versus 33% of the neoadjuvant arm, and N0 resection was 37 versus 10% in the neoadjuvant arm. So whilst this is a negative study, it did have higher rates of R0 and N0 resection that unfortunately do not impart a better overall survival. And other studies looking at similar questions include the Alliance and the PREOR-PANC 3 study. So the summary of this trial is, yes, you get better R0 resection, N0 resection for lymph nodes, but it just didn't confer to that survival that we see in so many other cancer types.
Which is important to remember. I mean, it's, as you say, it's a really good question. And I think it was for this for the difficulties that pancreatic cancer presents, it was a noble effort to try and put that in a study context, in a rigorous protocolized study context. You're going to have people who fall off. I think about 17% or 18% of patients in one group and 13% in another actually develop metastases before going to surgery. So you're going to have those patients that just progress really quickly. But it is a interesting and very good question about whether we can actually improve the outcomes for these. But it's worth noting that just because in one cancer, as you said, Josh, R0 resection confers a better likelihood of good outcomes, doesn't, you can't apply that same fact to all cancers. It's the same thing with the immunotherapy in gastric cancer study that you had.
Exactly. And it's a resistant cancer. So if the cancer was sensitive, really sensitive to chemotherapy, you'd expect to have better R0 resection rates, you'd better have complete pathological response, and we just don't see that.
It's probably a bit of an indictment on FOLFIRINOX in that we're giving it both to shrink the primary tumour but also to minimise or reduce the risk of development of micrometastases and kill anything that's there. And clearly the FOLFIRINOX is just not doing that here.
No, but one thing I would like to just flag before we move on is the toxicities were higher in the neoadjuvant arm, which I found fascinating. You'd expect it wouldn't be, but maybe because it's so resistant that the neoadjuvant chemo doesn't do much, the cancer grows, causes problems, and that's the outcome.
Yeah, but you do make a good point because there is a burden of evidence that giving neoadjuvant treatment, and this is across multiple tumor types, and I think pancreatic cancer is one of them in the quote unquote borderline resectable case, which this study didn't look at. It looked at patients who are upfront resectable on radiology. That neoadjuvant treatment is less toxic and better tolerated than adjuvant treatment, but again, results here suggest that that's not always the case.
Not always. But you know what is the case? Exciting HER2 therapies, but like zanidatamab. Michael, do you want to talk about Horizon?
We love some very good HER2 therapies, and for once it's not TDXD. So Horizon BTC01 is a study of anti-HER2 therapy in biliary tract cancers. Now, HER2 therapy in biliary tract cancers do not go together like peanut butter and jelly, as our American listeners may say, but it is an emerging biomarker in a small subset of biliary tract cancers. There is some data to suggest that in intrahepatic cholangiocarcinomas, HER2 amplification or overexpression is present in about 5%. In extrahepatic biliary tract cancers, it's about 20%. In gallbladder cancers, it's also about 20%. And in ampullary cancers, it's 27.9, almost 30% of cases will have a HER2 amplification or overexpression. And this is important because biliary tract cancers, like pancreatic cancers, are a subset of cancers that is desperate, that is crying out for novel agents and novel targets. There's been some benefit or some promise, I should say, in the FGFR or in the anti-FGFR space, but it always helps to have more targets. So Horizon was a single-arm phase 2b study of zanidatamab, and yes, I did practice that last night, monotherapy in HER2-positive patients who had progressed after first-line chemo, and this was defined as a chemo that had to contain gemcitabine, although there was quite a spread of first-line chemotherapies. There was obviously the cisplatin gemcitabine. A lot of patients had anti-PD-1, which is now standard of care with durvalumab. But there was a few patients who had a 5-FU-based regimen as well. I'm not exactly sure how you combine 5-FU with gemcitabine, but there you go. Zanidatamab is a HER2-targeted bispecific antibody that binds two separate HER2 molecules, which is thought to have a greater efficacy and greater activity than trastuzumab plus or minus pertuzumab in preclinical studies. So Horizon was broken up into two cohorts. The first cohort, cohort 1, inventively named, was HER2 positive, defined as a IHC of 2 plus or 3 plus. And cohort 2, this is the interesting one to me because this is all the rage across oncology at the moment, is the HER2 negative space, IHC 0 to 1 plus. Enrollment took place from September of 2020 to March 2022, and the time of data cutoff was October of last year. So, in terms of response, across the cohorts, the overall response rate was 41.3%. 32% had a partial response, and 22% had stable disease. The median duration of response was 12.9 months, and the median time to first response, this is probably my favorite result, Josh, was 1.8 months. So less than 2 months, you're getting a response on average. So it's a fairly quick acting drug.
Michael, that's probably as good, if not a little bit better than chemotherapy.
Yeah, absolutely. And it's particularly important because if you remember, these are patients that have progressed off first-line therapy. And as we know with these biliary tract cancers, it's very anatomically busy. That's what I always say to my patients. The area around the biliary tree, around the liver, you've got a ton of vasculature, a ton of anatomical structures there. So you are quite likely to be encountering problems. So you frequently need a quick response to salvage these patients. And so for the subset of patients that have a HER2 amplification or overexpression, it's worth noting that this is an agent against amplification or overexpression, not HER2 mutation. They are slightly different, or very different, I should say. They're completely different. You should consider an anti-HER2 agent if you have one available.
This is quite interesting, Michael. Just intersect briefly. Zanidatamab is, I was looking up the mechanism of action. We know it's an anti-HER2, but it's a humanized bispecific monoclonal antibody directed against two non-overlapping domains of HER2. So one of the things they found with HER2 agents, they become resistant because of deregulation, resistance to that of the monoclonal antibody, but they found with bispecific, which is kind of a sister to the antibody drug conjugate class, that by targeting two domains on the HER2 receptors, you can actually reduce resistance. And I wonder if that's why it's been so effective.
Entirely possible, and that's probably why they were comparing it in preclinical studies to trastuzumab and pertuzumab, which works in a similar way. In terms of toxicities, they were overall tolerable, fairly standard actually for anti-HER2 therapy, so diarrhea, infusion reactions, and there was small numbers of reduced ejection fraction. It is also worth noting that the patients who did have a reduced EF were confounded by pre-existing or concurrent conditions, and every single one of them was asymptomatic. Small numbers again, but we did not actually have patients go into florid heart failure requiring cardiology input, the likes of which you can listen to in our Mark Nolan episode on cardiotoxicity, a bit of a pitch there. So in conclusion, zanidatamab is promising in the anti-HER2 biliary tract cancer space, demonstrating fairly robust anti-tumor activity with an excellent speed of response, which obviously is good for patients. Considering that this is the second-line therapy where we're looking at a median survival of 3 to 6 months, if we're being generous, there was a very good duration of response at 12.9 months. Toxicities were manageable, and the authors are planning further studies, including combining zanidatamab with cisplatin and gemcitabine. So again, it's moving on up and definitely a player to watch in this space. And I think a takeaway message, just sort of in general from this study, is, and we mentioned this previously, test your biliary tract cancers for HER2, because whether it's an access program or a clinical trial like Horizon, it is a very important thing to keep in mind because you may open up therapeutic targets.
Wise words as always, Dr. Michael Fernando. I think that concludes today's episode on Upper GI ASCO update. Stay tuned for tomorrow where we come back for breast cancer.
It's 2 big episodes to start off, but we are very excited.
See you then.
Bye. Thank you for listening to Oncology for the Inquisitive Mind. You'll find previous episodes on our website, along with weekly posts, resources, and links to our Twitter and LinkedIn pages. Check it out at inquisitiveonc.com. That's inquisitiveonc.com.